the Department of Psychology here at Drexel, and in particular, both work with Dr. Naomi Goldstein in her lab. And I would like to begin by introducing the first of our two presenters, Leah Brogan, and then when Leah finishes, I will stand up again and introduce the second presenter. So Leah is going to be presenting on substance-related disorders in justice-involved youth, particularly diagnosing strengths and weaknesses and current diagnostic criteria. She's finishing her second year. Her PhD will be in clinical psychology with a forensic concentration, and her general research interests involve juvenile delinquency, in particular factors influencing risk-taking behavior with justice-involved youth. So please welcome Leah Brogan.
Hi everyone, thanks for having me today. And thank you, Dr. Heilbrun, for a very nice welcome. So I'm Leah, I'm from the Department of Psychology, and this afternoon I'll be discussing the developmental appropriateness of the newly revised Diagnostic and Statistical Manual of Mental Disorders, Substance-Related Disorders Criteria as applied to youth, and its use within justice-involved settings. So, for those not in psychology, what the heck did I just say? So, the Diagnostic and Statistical Manual of Mental Disorders, also known as the DSM, now in its most current version, DSM-5, is the American Psychiatric Association's classification and diagnostic tool for mental disorders, and it serves as a universal authority for psychiatric diagnoses among many mental health clinicians. So it was released in May of 2013, and it superseded the DSM-4, which was published in 2000. And given the recent publication of DSM-5, little research exists right now regarding this issue of whether or not it's substance-related disorders criteria, so that meaning substance disorders being alcohol use disorders, nicotine, cocaine, methamphetamine, stimulants. In the past, these have been described as substance abuse or substance dependence, so it's under that umbrella that I'm speaking about in terms of the criteria. So little research exists regarding if substance-related disorders criteria is developmentally applicable to adolescents. So today, I hope to provoke thoughtful consideration of what's already known regarding DSM criteria, as well as the utility and limitations of its revisions, and future directions to strengthen its applicability within adolescents. And throughout the presentation, I'm going to refer to substance-related disorders as SUDS. So before we jump in, here's a quick snapshot of my academic research projects and interests. So Dr. Heilbrun said I'm a second-year clinical psychology doctoral student in Dr. Naomi Goldstein's lab. And in our lab, we focus primarily on issues relevant to justice-involved youth. So I'm currently in the process of completing my master's thesis, which is entirely different from this presentation. So I'm evaluating the utility of a standardized forensic mental health assessment tool that's used in cases involving defendants' legal capacities to validly waive their Miranda rights. And as it currently stands, this tool, referred to as the Miranda Rights Comprehension Instruments, has been validated for use with justice-involved community youth. So what I'm doing is I'm ensuring that the MRCI is a reliable and valid instrument to use with incarcerated adults' legal capacities to validly waive their rights. So much different, but I thought I would give you a heads up. My other research interests with justice-involved youth research include risk-taking behaviors such as substance use, which I'll get into in this presentation, as well as the evaluation of treatment programs designed for justice-involved youth, such as diversion programs or evidence-based treatment programs and community-based mental health outpatient programs. And I'm also interested in the implementation of trauma-informed care given in juvenile justice facilities, given the high rates of PTSD in this population. So that's me in one PowerPoint slide. So back into the presentation. So why is developmental appropriateness important? Well, nearly 70% of the 2 million youth annually entering the juvenile justice system meet criteria for at least one mental health diagnosis. And many of these youth also meet criteria for a co-occurring substance use disorder. So research finds that justice-involved youth have a higher likelihood of substance abuse problems than non-incarcerated youth. And there's considerable evidence linking youth substance abuse and criminal involvement, which suggests that substance use assessment and treatment be considered an integral component of youth rehabilitation while incarcerated. And however, scarce resources and a high substance abuse treatment need inherent in the juvenile justice system require careful consideration and selection to reduce youth substance use. So in light of these challenges, one needs to consider the role of mental health diagnostic criteria in accurately determining the absence or presence and severity of a SUD. And given its recent publication and modifications to the substance-related disorders section, my question is whether or not DSM-5 SUD criteria accurately addresses the pitfalls of former DSM versions and improves diagnosing and effectively treating problematic youth substance use, or if it exacerbates them and ultimately leads to increased reoffending among substance-abusing, justice-involved youth. So represented here are results from the Substance Abuse and Mental Health Service Administration's 2012 survey on drug use and health. And in comparison to older individuals, youth abused or were dependent upon substances at substantially lower rates. However, other results from this survey revealed youth's diminished risk perception of using particular substances frequently and easy access to several illicit substances such as marijuana, cocaine, LSD, and heroin. And the reason why I'm showing you these results is to really echo what the research shows us today, which is that early adolescent substance use consistently emerges as a robust predictor of future substance use and criminal involvement. So what does substance abuse look like in a justice-involved sample? So displayed here are findings from Kaplan and colleagues' survey of male and female juvenile detainees. And over half this sample met for at least one major psychopathology diagnosis, and nearly 50% for a substance use disorder alone. And rates of juvenile offender substance use disorders reported throughout the current research were variable, but typically higher than the general adolescent population. However, in most samples, justice-involved youth don't meet for a clinical diagnosis, which may be a reflection of variability in the diagnostic criteria used to define the disorder. And variability in reported rates of justice-involved youth SUDs illuminates the pitfalls of applying the same diagnostic criteria to both adults and adolescents. So this may result in some adolescents falling short of diagnostic thresholds, making treatment decisions very difficult. So overall, these variable rates imply that substance use disorders within justice-involved youth are prevalent, and further it suggests that there's a high need for diagnostic criteria that accounts for youth's unique neurodevelopmental vulnerability and risk-taking behaviors such as substance use, which actually may not truly meet for a clinical diagnosis, warranting excessive and costly treatment. So what exactly is happening in the adolescent brain and their social sphere that heightens their sensitivity to sensation seeking, especially in the form of substance use? Well, we know that adolescence is a critical period of neurological, social, cognitive, and emotional development that may heighten youth's vulnerability to the deleterious effects of substance use. And increases in incentive reward motivation during adolescence heighten youth sensation seeking for salient rewards. So unique neurodevelopmental changes such as maturation of neuronal structures and changes in local dopamine transmission, they facilitate reward-seeking behaviors such as using illicit party drugs or a cigarette between classes. Additionally, synaptic pruning and myelination of frontal subcortical neuronal connectivity provide refinement for executive functioning abilities such as memory, planning, and inhibition, all of which are useful for considering the consequences of using novel party drugs in a stimulating atmosphere, such as a rave or a party. So these neurocognitive and neuromaturation changes are gradual, and reward circuitry is highly influenced by experiences that offer salient rewards, thus leaving youth cognitively ill-equipped to maturely consider possible adverse consequences associated with risky behaviors such as alcohol and drug use. So substance use can significantly alter natural development of the adolescent brain and interrupt the neurocognitive maturation needed for successful academic, occupational, and social functioning in adulthood. So the substance use disorder criteria are now separated into 11 criteria which regard substance use severity along a continuum. So criteria 1 through 4 address impaired control, criteria 5, 6, and 7 concern social impairment, and criteria 8 and 9 comprise the risky use symptom category, and criteria 10 and 11 comprise the pharmacological symptom category. Now comprising this last category is tolerance, which is defined by the DSM as a need for marked increases in a drug to achieve intoxication or a desired effect, or a markedly diminished effect with continued use of the same amount of substance. And withdrawal, defined as a physiological response to declining blood or tissue concentrations of a substance within an individual after prolonged heavy use of a substance. These two criteria are no longer required for a SUD diagnosis, as was the case in previous versions of DSM. So now, SUD severity is now characterized by 3 categories. So a mild SUD is characterized by the presence of 2 or 3 symptoms, a moderate SUD by the presence of 4 or 5, and a severe SUD by the presence of 6 or more criteria. So changes made to the former DSM criteria reflect a movement away from the categorical approach toward a more dimensional approach to defining substance use disorders. And these modifications strengthen the utility of the DSM-5 SUD criteria in diagnosing youth substance use disorders. However, these changes only partially rectify the developmental inappropriateness of former DSM SUD criteria. And the pharmacological criteria concerning both tolerance and withdrawal so the pharmacological criteria concerning both tolerance and withdrawal are no longer required for a SUD diagnosis, as was the case in previous versions in DSM. However, the revised criteria do not seem to better account for the heterogeneous and subtle patterns of adolescent tolerance and withdrawal. So tolerance, as I said before, which is a marked increase in amounts of substances to achieve a desired effect or intoxication. This may actually be a common developmental phenomenon among youth, since adolescent substance use, such as alcohol use, sometimes occurs in a binge-like manner. Alongside not wanting to reveal illegal substance use, the developing and very vulnerable adolescent brain may not be able to really fully understand complex screening questionnaires or their physiological response to different dosages of a certain drug. So what do I feel like when I have 2 joints as opposed to a whole bowl of marijuana? Or even their physiological response to discontinuation of the drug. You know, am I in withdrawal from alcohol, or am I hungover because of a night of binge drinking? So to kind of better understand and get at tolerance and withdrawal in adolescence, it may be best to employ time frame specifiers such as 3 months, 6 months, and 1 month to get at the frequency and level of consumption and physiological withdrawal from particular substances. So the hazardous use criteria now comprises the risky use symptom category. And prior to the addition of this hazardous use criterion was the legal difficulties criteria, which basically lowered the threshold for youth to need for an alcohol use disorder by realizing that alcohol use was in and of itself a negative consequence. It was illegal. So in place is now this hazardous use criteria, which much research shows inherent gender, culture, and age biases. So some suggest that it might be a better indicator of adolescent conduct disorder and adult antisocial and personality disorder. So the new craving criterion, the operational definition of it, which is strong appetitive urges or a desire for a drug in a particular environment, especially the environment in which it was first obtained or used, will impact its observed prevalence in adolescents, but more research is needed to really validate its utility in diagnosing SUDS in youth. So finally, the 2-symptom threshold for a mild set diagnosis may select for mild cases which do not demonstrate compulsive patterns of drug seeking or drug use. And this low threshold may overemphasize developmentally expected adolescent substance use experimentation that has a high potential for remittance. And overall, this may result in overdiagnosing sets of youth, imposing upon them a stigmatizing mental health label that may jeopardize their successful transition into adulthood. Thus, some suggest avoiding low symptom thresholds for diagnosis. So evaluating youth's diagnostic thresholds for SUDS within the DSM-5 framework is vitally important to informing the juvenile justice system's approach to treating youth substance use disorders. Oftentimes, judges will mandate substance use treatment for adjudicated youth based on history of use rather than the presence of problematic substance use. And juvenile justice facilities and community programs are often ill-equipped to fully and thoroughly assess for youth substance use problems, resulting in these one-size-fits-all treatment packages regardless of the presence or absence of a SUD diagnosis. So one-size-fits-all treatments coupled with developmentally inappropriate SUD criteria may subject youth within the juvenile justice system to irrelevant or unnecessary treatments, impose upon them stigmatizing mental health labels that may jeopardize their successful transition into adulthood, and diverts scarce financial and treatment resources away from those justice-involved youth with serious substance abuse problems. So taken together, these challenges prevent juvenile justice facilities from addressing youth's criminogenic needs, which are those that predispose one to reoffending and ultimately could promote reoffense. So in sum, research finds a high prevalence of problematic substance use within youth entering the juvenile justice system. The revised DSM-5 SUD diagnostic criteria only partially rectifies former DSM SUD criteria, developmental weaknesses, and gaps still exist in the criteria's ability to capture the unique and vulnerable nature of adolescent development that predisposes youth to problematic substance use. And in the context of juvenile justice settings, developmentally inappropriate criteria may result in overdiagnosing of youth who engage in problematic substance use that has a high potential for remittance, and or fail to provide a clinical diagnosis for youth with genuine substance use disorders. So doing so will divert scarce and costly treatment resources away from those youth who need it most. Developmentally appropriate diagnostic criteria has the potential to improve and provide for sounder assessment of youth's problematic substance use issues, which can improve resource allocation within the juvenile justice system and the youth communities, and holds very strong implications for reducing recidivism altogether.